Right, we'll kick off as a few of you make your way to seats. Good morning, everyone, and welcome to a slightly damp Painswick. I'm Alec, Price-Forbes, National CCIO, and I'm still a practicing rheumatologist 1 day a week. In fact, because I've had a few days off for half term, my Monday evening virtual clinic didn't get cancelled. The face-to-face one did. We all know that burden and pain. So tonight, before dinner, I'll be doing some video calls with patients. So I'm still in at the coalface, as it were. Thank you to Mark and the colleagues, and thank you for the invite. Really delighted to be back in Painswick, and a slight personal story. It's somewhere quite close to my heart. Probably 25 years ago, my wife spent a year working in Gloucester, but living in Painswick. And we chose to get married here. So 21 years ago, we got married in the Painswick Hotel down the road and took over for the weekend with all of our family and friends. So it's lovely to be back here. I'd recommend, if you've not been here before, come on a summer's day. The views across the valley are amazing, and I'm hoping to try and turn back the clock and go for a run tomorrow morning. I used to be able to do it in a certain time. I suspect I won't be keeping to that time tomorrow. Anyway, we are here to talk digital, and I'm probably going to talk a bit of digital sandwiched between talking about people, as I've already have. And we could retitle this and talk about what is a life well lived, and let's talk lives. Because ultimately that's what we're trying to do, is improve the efficacy and length of people's lives to live the life they want to. And I've reflected a lot on that, having lost my mother to dementia last year after a 6-year battle in an amazing nursing home, which we brought her to near where we live in the Midlands. And it was humbling, really, seeing what I think is a lost sector, which is the care sector. We don't talk about it enough. But given the rise of dementia as one of the big killers now, it's really humbling to see the incredible way in which the care sector look after our loved ones. And we need to be really mindful of that as we look to move forward. So we have a challenge ahead of us. And as Darcy's investigation, with this esteemed audience, I don't really need to rally too much on this. We've got a real challenge that in particular, the slide isn't showing in the display for some reason. Anyway, I'll just have to talk. You have to assume there's some magical invisible writing within those boxes. So the future of the NHS is unaffordable in its current guise. So currently we're spending around 11% of GDP. Around 40% of that is on staff costs, and it's rising. So there's a real challenge. It's not sustainable, and projections are over the next 5 years that the NHS as we know it will not be affordable unless we do something radically different. Workforce. 1 in 10 of the workforce left last year. 5.6% of the workforce are off sick. We have untold challenges, really, from an administrative burden perspective, where we need to really equip our workforce with the skills and the competence to be able to use what's in front of them and put a smile back on their face to enable them to deliver care, which is what they've come in for. 6 out of 10 of our public said they were dissatisfied with the NHS last year. 60%. And most of that is around access and waiting times for clinics. People are living longer with ill health. So life expectancy has been rising for the last 70, 80 years. You'll have seen in the Marmot review in 2020, lost really with the pandemic, that in some areas of this country, life expectancy, healthy life expectancy was starting to stall. But there's no doubt people are living longer with chronic disease. And the forecasts, recent studies from the Health Foundation have suggested in the next 5 years that it'll be 1 in 4 people have chronic comorbidities, and with more than 5 comorbidities impacting on their lived experience. So there's a real challenge, and inequalities is writ large across all of this. So we've got a challenge. The 10-year plan is the government and the NHS's revitalised way in terms of addressing some of these challenges. And at the heart of that is really starting to focus on person-centered care, holistic care that returns to what I call the art of medicine, where digital data technology is enabling us to do things in a radically different way. And we need to do that because of the demand, because of the productivity issues. I hate the word productivity, by the way. Just put out there. I was listening on the Radio 4, coming in, people talking about, are people more productive working at home? The answer is yes. I commute to London, I spend 5 hours commuting, trying to get on to Wi-Fi on a 30-year-old train. Just doesn't work. So of course we're more productive at home, but you need to be able to do what you need to be able to do. And we recognise that compared to pre-pandemic activity levels, where you had 2.7% increase in productivity in the last year, unfortunately, activity levels in terms of outpatient appointments, elective procedures, and other activity is less than it was in 2019 with more staff. But in some areas, staff numbers are dwindling. So there's a challenge there and a bit of a paradox. I've already said about the plan is absolutely embedded around digital. There's 121 specific initiatives. Dare I mention AI? It's mentioned 300 times in the 10-year plan. We'll come back to that. But there isn't going to be more money. Whilst there's a 10 billion investment in technology over the next 3 years, we can't carry on doing the same. We've got to do things radically different to, in effect, deliver the quintuple aim. We've known about the triple aim in terms of improving population health, improving quality and experience of care when needed at a sustainable cost for decades. We've known about the quadruple aim for 11 years. And then the quintuple aim came about adding in inequalities to looking after the workforce during the pandemic. But we're still, as Darcy said, in the foothills of true digital transformation. In essence and in short, we have digitized what we did on paper and hoped that it would bring productivity and quality gains, and it hasn't. Put another way, I'm afraid the NHS is currently in an analog way like Blockbuster in the world of Netflix and Apple TV. And we need to radically shift the conversation and the way we do things if we're going to address some of the challenges. So I'm really sorry slides aren't, for whatever reason, the formatting's not to come out here, but we'll share the slides, you've got them. So the shift in service delivery needs to encompass both the change in the clinical as well as the business operating model, which has been too long predicated on a transactional way, as I would put it, of let's see how many patients we can see in a year and not worry about outcomes. We've got to move towards outcomes and values-based practice, where people get the care they need in the place that they need it. And I think that's critically important. We need to be data-driven, and we need to use evidence-based. We need connected, interoperable systems that talk to each other, so data flows in an actionable and structured way. And we need smart automation, and that's where AI can truly start to be leveraged to reduce the admin burden for our staff. So we're talking now about a framework where we talk about digital by default, and that's the current language we're talking about at the centre, and it's how we enable that that's going to be key. And how much of that is done from the centre in terms of obviously the investment in national live services. We have 300 that keep the lights on for the NHS, 16 of which are critical to national infrastructure. But care happens close to home. So it's about doing digital at the centre when it's right, but enabling that local development to prioritise what's needed for the communities in which people live. And we see sort of the 3 levels really, which is everything should be digital and start with a digital by default, but recognising there'll be some who can't avail themselves of that opportunity, and that's where repurposing staff will be critically important. I say to my secretary now, rather than filing paper notes and paper results and typing my letters, because they don't do that anymore, have become a patient navigator. And I think that's going to be critically important in terms of those role changes as we move forward. And really making face-to-face contact when it's really going to add value and be of the essence. So this just really highlights nationally provided solutions where it's appropriate to eliminate that postcode lottery, but enabling local regions, the 7 regions, and the systems within it to really flourish in terms of what's required for their areas. Filtering out those that can't avail themselves of digital services, as I've said, by enabling staff to help support them. So we really address digital exclusion. The proposed single patient record, for which options appraisals are being worked up at the moment, which will enable both the patient, citizen, as well as the health and care professional to have full access to actionable, clear, structured data that's real time and really start to diversify towards personalization for care delivery. So this is page 38 of the 10-year plan. I know you've all read it cover to cover and would know that, and I won't test you on other pages later. But I think it's really important, the phrase, care should happen as locally as it can, digitally by default, in a patient's home if possible, in a neighbourhood health centre when needed, in a hospital if absolutely necessary. That is the direct polar opposite to what we have at the moment, which is a health and care system where 93% of spending has been going on acute trusts and dealing with the flow of ambulances at the front door. We've got to shift the model if we're having the left shift, to stop reacting and responding to people who've fallen into the river of disease, whether that's through health problems or wider social determinants, and actually focus on preventing them from falling into that river in the first place. And that focus has got to, from my perspective, be focusing on wider social determinants which impact on people's lives and lived experience. And that major shift will look at improving user experience, improving productivity, and care quality. And the new National Quality Board is going to be focused, there's three pillars really. One is looking at safety of the systems we put into play, one is looking at the effectiveness and impact, and one is looking at experience. And I think those are three things we can firmly get behind. So how will we get there? So some of the core capabilities and technologies, really a revitalized and rebuilt NHS app, dare I say, that is really fit for the 21st century in the age of Apple TV and Netflix. Other providers do exist. Connecting the NHS with a single patient record, being data-driven with all of our decision-making, and really making sure we evaluate and research. So we do all of these things in parallel, as well as training the workforce and equipping them with the skills we need. Those delivery shifts, and you've heard about the three shifts, into community, into prevention, and digital-first models really require a different focus on implementation. And just to labour the point, we've put lots of digital in, but we've not invested in people. We've not invested in reimagining care or business process and the operating model, and we've not done change management. And therefore, we've not realised all the benefits writ large in lots of business cases up and down the country. So we've got to change the model and have an implementation model, which means we've delivered the benefit. We've delivered and improved outcomes for the people receiving care, as well as sustaining the well-being of the workforce. This is typical for anyone who sees a patient. This was a 78-year-old delightful lady, came in as a new patient 3 weeks ago, and with her husband. They both had iPhones. They both had, when I asked them, they both had the NHS app and sort of used it, sort of didn't. And I said, well, why don't you use it for your medicines? Oh, well, I prefer my laminate. This was a beautiful laminate. On the other side was her name, address, her next of kin, her date of birth, her blood group. And I was saying, but you're going to have to, I'm going to be changing her diagnosis. She hadn't got PMR, she got rheumatoid arthritis. So I'm going to have to change your medications now, and you're going to have to put lots of biro over this. How's that going to work? She said, oh, I'll print off another one. It illustrated to me that we've got a 78-year-old who uses phones, has a smartphone, lives digitally in many respects, but still likes the analog. How do we address that? That's going to be a big culture shift, but equally we need to be respectful of people's preferences. So some of the things supporting that transformed model of care, the vision really is a third of patients by 2030 will be using purely digital channels, which will empower their ability to navigate health and care when they need it. So access, triage and navigation intelligently using AI through the NHS app will provide a similar service to what we do when we do our banking and we do other aspects of life. But enabling people to get to the right information at the right time, but also be navigated to a service if they need to see somebody. Transforming care pathways, giving personalised information through the NHS app, because we can start to build out and know what's wrong with them and what their care needs are, at home and community-based, and really making the NHS app a companion that people default to go to, but recognising there'll be some that can't, and therefore proxy access and other aspects will be needed. So there's lots we need to do. Why do I end with a symphony orchestra? Well, irrespective of the great capability of digital data and technology, at the end of all of this are people. And we need a big team. In another life, I was a violinist. My best friend who plays professionally played at our wedding just down the road, as I said, 21 years ago. And I was told to do medicine and keep music up as a hobby because I could do that. They lied. Career advice at school was atrocious. And I went 30 years not playing violin. I rejoined Stratford Symphony Orchestra during the pandemic, which has been an incredible pleasure, not least because I've gone from sitting on the front desk, leading or co-leading orchestras, to sitting at the back of the first violins. It gives a different sound and visual experience, but hopefully we're still playing the same music, the same notes in the right place and the right piece. There's something about how we need a symphony of talents, of people to come together. How many people went to Coldplay in the summer? Wow. You are the first audience not to have been to the phenomenon. In a time where geopolitically life is challenging, I've stopped listening to news. My wife still wants to listen to the news at 10 o'clock. I've stopped. You can predict that it's just going to be depressing, and why do you want to be depressed when you're about to go to bed? So I go and escape and read a book or do something different. But there was something very special and a restoration of humanity of what Chris Martin did with 250 performances across the world over a 2-3 year period, in terms of the repeatability and the consistency with which he was delivering an incredible experience. And my son and I got tickets and went to Hull. We drew the short straw because my wife and daughter had already got tickets for Wembley. They got a year before and said that they were going. They could only get 2 out of 4 tickets, and they were going to take those 2 tickets, so that's great. Equality lives large. But there was something incredibly powerful about whether you were in Hull or whether you were in London or any other part of the country. Everybody says the same word to describe it, and it was amazing. Wouldn't it be great if every experience and touch point a patient has with health and care on a daily basis was described as amazing? And for me, the best of digital data and technology has the opportunity to restore holism, restore the art of medicine, which I think is so incredibly important. Because at the end of the day, we have an enormous business that has to be run with the operational efficiency of a modern factory. And yet, healthcare is an exquisitely human endeavour where we have the privilege to touch the lives of people, both at the best of their lives and at the worst of their lives, for them and their family. It's all about data and science, and yet it's all about what I call the art of medicine. So the symphony here that inspires me, and the call to arms for all of us, is to create the world's largest, socialised, integrated, personalised, digitally enabled and data-driven learning health and care system, where the best of science and technology can truly enhance and improve all our lives. Thanks very much.
Thanks very much. Okay, so I'm Marcus Bohr. I'm a GP and clinical informatician. I'm a self-taught software developer. I'm from Yorkshire. I'd just like to welcome you all to the conference. You'll find it's a very different conference to what many of the sort of health tech conferences that are available. It's different in good ways, in that we've got a really interesting range of people here who've come out to a very unusual little sort of place. But the smallness of this conference, I think you'll find, is a very interesting and different experience. So I'm not going to say much more. We are a little behind, so we're just going to move straight on to Sarah Murray, who's going to talk about the patient's perspective.
Thank you very much. I'd just like to start by saying I'm using paper. I don't use PowerPoint. You can close your eyes, you can just listen. I don't require any other interaction except for that. But I'd like to thank Alec for his talk. There's a huge amount I'd like to discuss with you because I think you hit on some very, very important things. Firstly, I am the patient advocate, but I'm not Mark's first choice. I think it's fair to say, because the previous speaker in this role is sick. And that is the point and the reason why we're here. Because we're talking about people who are sick. They're not in their best game. They are frightened, they are lonely, they are isolated often by their illness, and they are lumped with a title they hate. They don't want to be seen as a patient. We send people into hospital, we put a gown on them, we let their backsides hang out, and we say, it doesn't matter whether you're a CEO, it doesn't matter whether you're the best programmer in the world, you're just a patient. You're the patient in bed number 2. And you're going to sit on a squeaky mattress, and you're going to be surrounded by a blue curtain, and you are just the clip at the end of the clipboard at the end of the bed. And that's really important, because we diminish people the minute they go into the system. We don't mean to, but we do. And the comment I hear constantly from people is, I just don't want to be seen as a patient. I am me. So patient-centered care we talk about, and it is really important, because they don't want to be there, they don't want to have what they've got, and they want to be out the door and living their lives. So how did I get into this? So I'm fortunate, I'm not a patient, but my son is. My son was born with a congenital heart defect, and at 3 days old he had an emergency operation because he started dying 6 hours after he was born. We were in Belgium. So we went from a cottage hospital. He was born on a Friday, so the gynecologist could go and play golf. So, and spent the weekend in a cottage hospital, and he was in the neonatal unit. And by Monday morning, he was being blue lighted to the paediatric hospital on the other side of the ring in Brussels. He was operated on 6 hours later after having fitted, because they couldn't do an angiogram and they had to change his medication. And this tiny little baby was going all over the place. I was spoken to in French, German, and Flemish, and we ended up drawing diagrams to understand what we were doing, what they were going to do. And it was the best care he ever had, because they saved him. But they also admitted after 3 weeks that it hadn't worked. And they said, you need to go and get a second opinion. So we came back to the UK and we went to the Royal Brompton. And he was managed at the Royal Brompton up until the age of 16. 14 he had a stent, 16 he had his first open heart surgery, Ross procedure. And we latched on to looking at the surgeon. And we looked and we listened as hard as we could. And both my husband and I are lawyers, so our file was nuclear edged. I mean, it really was. They were terrified. They said, what did we do? What do we do for a living? And my husband very blankly said, I do litigation. And so we went into it. We took our daughter with us. And it was fascinating, because our daughter's 2 years younger than our son. And we'd asked all our questions, how long will it take? What's the recovery period? What medication, how long is he going to need to recuperate? And our daughter said to the surgeon, show me your hands. And he put out his hands. And she said, show me your shoes. He said, you have clean shoes and your hands don't shake, you can operate on my brother. And the reason I give you that example is because things are very basic with people when they're frightened. They take it down to the lowest common denominator. So we talk about all of this wonderful digital age, but the reading age, the national reading age in this country is between 8 and 12. If you want to understand what people understand, read the Daily Mirror or the Daily Star. They write in short sentences and they use very, very few words. Want to understand how to write a sentence? Read those papers. The socioeconomic level of most people is very low in this country. So whilst we all say, oh, everyone's got a computer or a smartphone, many don't use it. They either borrow them, or we have Bangladeshi women who live in large families whose son operates it, or their grandson operates it, and they don't have any access to it. So we have a real mountain to climb to get people to understand. So I work with cardiac research. I now am the chair of PPI, Public Patient Involvement, for cardiac research trials. And we started with no cardiac research trials, and we now have 12 long-term trials going and 27 million in the bank. And that's because We have taken public patient involvement from the very beginning, and it's going all the way through to the end. We are trying to develop electronic informed consent forms. Because what we don't understand, and what I have tried to bang on for a long time, is how do you understand what I'm consenting to? How do you know that I have understood what you're saying? And I was talking to a friend of mine yesterday who's just had open heart surgery. And I said, what's the one message that you would like to say to this group? And she said, you can't know about it until you do it. And she said, I have had all the information in the world. I have had people explaining it to me, holding my hand, but you can't know it until you're going through it. And if there's one thing I would ask all of you, is just think about that, because it's critical. And we are all potential patients, all of us. It could happen to any one of us, and it's probably happened to your family members. But it isn't the same for you as your family member. It isn't the same for me as my son. So that is the one message. In order to understand a person, you have to walk a mile in their shoes. And with all the digital assistance in the world, and with all of the great diagnostics that we can come up with, yes, of course we can make people's lives better. I've no doubt about it. And the biggest question we want is to improve the quality of life. Nobody that I have ever come across as a patient wants to live forever. They just want a good quality of life. And in that is implicit, they want a good quality of death. And I don't mean assisted dying, but they don't want to be kept alive forever, as Alec said, with a worse quality of life. They want to live their life well for as long as they can. And that is key. And I think the important thing with all of these diagnostics and all of this great digital imperative is at the end, there needs to be good communication. You can have the best diagnostic in the world, but if it's poorly communicated, it can send someone into a flat spin. If you're not listening to what somebody's saying, if you realize that actually people don't listen, they see. They don't see, but they listen. They only communicate by touching and doing. We all learn different ways. We all take on education in a different way. I was a governor of a college, and we used to spend hours trying to work out kinesthetic education, whether you were oral, audio, how students learn and how they take on information. And you ignore that at your peril. If you think that you can just give them something digital and it'll all go in, dream on. Because some people have to have taken it through, they have to have talk about it, they think about it, they debate it, they chew it, they turn it around, and then they'll tell you whether they agree with it. Or they pick up the phone and then talk to someone. So what I'm saying is communication is so important, and at the end, it's kindness. It's sitting with the surgeon next to you, holding your hand, looking into your eyes, and explaining things to you. It's getting that connection. We have had digital interactions for decades. We've been humans for millennia. We live by touch, by knowledge, by sense, by feel, all of those senses. And it just doesn't always come out of a computer or an app. So if you can work out a way today, this is my challenge, where you can get that human interaction into your app, or you can improve the communication, and you can understand what motivates everyone from every socioeconomic, ethnic background going, then you will have cracked it. Because actually, it's the hand held, it's the look in the eye, it's the kind word that goes so much further than something that says, you've got this. And I'll give you one final example. So my son had endocarditis 2 years ago. It was awful. He has a mechanical heart valve. It was his second open heart surgery. And he'd gone in and he thought he'd had flu to his GP, and the GP said, don't leave the surgery, you're going straight to hospital. He phoned me and he said, I've got my bag. His fiancée at the time was at work, and he said, can you come with me? So we got to A&E at 5 o'clock in Southampton Hospital, and we got seen at 2 o'clock in the morning. And when they looked at him, they said, oh, this isn't very good. We'll get you a bed. And the following morning, I went in at 6 o'clock in the morning, having got him settled. And there were 3 cardiologists standing around with a clipboard, and he was sitting in the bed with the usual gown on the squeaky mattress with the blue curtains. And everybody looks very grey when you've got those blue curtains. You look really sick. Horrible things. And one cardiologist said out loud, of course, we can always whip out the valve and put a new one in. And they were thinking aloud, and they were looking at screens, and they were looking at all of his diagnostics and saying, well, we can do that. It took me from 7 o'clock in the morning to 11:30 at night to get him back into that bed because he was discharging himself. He didn't care if he died in the pavement. He really didn't care because that loose comment of that one cardiologist sent him over the edge. We walked around the hospital, we went to Costa Coffee, we went to Cafe Nero, we went to Marks and Spencer's. We walked all the way around the graveyard, which is quite desperate, I have to say, if you have to go out of the hospital straight to a graveyard. But the point I'm making is communication is key, and you can have all the diagnostics in the world, but if you don't use what you have been given, your own voice and your own thoughts, and the way you present it to patients, you lose the point entirely. Now, they got him out of hospital 3 weeks later, and he hasn't had it since. He's got a temperature today, so I'm a bit jumpy. But the point I'm making is communication, communication, communication. This is assistive. This will save lives. This will improve patient care. But it's actually how you talk to patients that matter. And above all, please be kind. Thank you.
Really interesting talk there, and I think hitting some points that this conference is not afraid to hit, as in, there is an elephant in the room. It's on the third row there, next to Nina. We always have that here, and it's because it's talks like that that say, actually, digital is not enough by itself, and I think we are in danger, I think, with the 10-year plan of slipping down a hole where we put all our trust into digital, and we aren't thinking about where the communication skills for the future are going to come from. Those are the areas that we can talk about here, and I think that's one of the nice things about this conference, that we're a little bit, we're the punks. We're not Coldplay, we're Gogol Bordello. We're there telling people to change their ways because it's not good enough. So right up next, we've got James Freed, who's going to talk to us about 3 practical steps to make your workforce more digitally confident and competent. And then we're going to go straight to the Q&A at that point, and that will let us catch up. And Anil Krishnanaya, who was on the bill, is not here. Hamza, who is taking his place, will be later.
Thank you very much, Marcus, and thank you so much, Mark, for inviting me. It's a great pleasure and honour to be here. Sarah, I'm going to take your challenge. I think that's a really important one. So you were talking about kindness and human-centeredness. Now, my world doesn't tend to touch directly on patients, okay? But I am going to take those themes, if I can. You can hold me to account if I don't. So I'm James Freed. I run something called the NHS Digital Academy. I'm going to tell you a little bit about the Academy, and then I'm going to try and give you some practical steps, things that we've learned, and I suppose why our workforce also needs to be treated with an element of kindness and human-centeredness, because it's hard for them too. So this is our mission. We exist to try and support every single member of NHS workforce to develop the digital and data skills needed to enable the best possible healthcare services. So it's that end in mind. That's the reason why we exist. And I'm going to tell you a little bit about why now. So as Alec said right at the beginning, digital health technologies exist everywhere. It's very difficult not to stumble over them in the day-to-day working of delivery of health and care services, but they don't always deliver what we need them to do. So when we talk to our workforce and we ask them what they think of the technologies that we've provided them, they rate it at about 6 out of 10, which isn't terrible, but it is a net detractor score. Incidentally, when I ask this same question of people like you, so people who come from a digital health background, what do you think the users of your services would rate out of 10? The average is 4 out of 10. We've actually got a slightly pessimistic view, perhaps, of what our service users experience. I should also say, we know the digital technologies we ask people to use are not great. It's not surprising, and we're not alone. If we look at all digital transformations across the world, across all industries, about 70% of those, and this is data from the Boston Consulting Group, they looked at almost 900 different digital transformations, about 70% of them failed to meet the benefits set out in a business case. About 26% of them failed to meet even half of the benefits set out in the business case. I don't have data specifically for the NHS, but I would contest that the NHS, one of the most complex industries in the world, is going to have a better success rate than other industries. I think this is pretty much par for the course. That means that on average, the thing that you are building right now is unlikely. It's got a less than 50-50 chance of meeting all the benefits that you're expecting from it. So you can kind of see why people aren't giving us a 9 or a 10 out of 10 score. When we spoke to those people, so your service users, about why things were going wrong or what happened, they gave us a whole long list of things that are going wrong with digital health technologies. Now, I first started getting involved in the digital health scene with the National Programme for IT, right back in 2003. Don't blame me, it wasn't my fault. But thank you. But that list of issues hasn't really changed. When we did that research and we saw that, it was a bit depressing. We went on to ask why, how could we fix some of these things? And that was where it got a bit interesting. But these issues remain. People don't feel as if they are being trained in the technologies they're being asked to use. Sometimes they're not released for training. Sometimes they don't even have access to systems that they're supposed to be using, or even devices. The infrastructure that we put in is slow, it's difficult, it's hard to engage with, and the systems that we use are, in fact, our user base said, fundamentally unusable or unavailable. And this results in a number of issues. We know that the data from electronic patient record rollout, arguably the best data anywhere in the world on any type of platform, we know that there is a correlation between staff satisfaction and patient safety. And when people are less satisfied in using the digital product, patients suffer, right? It's a well-published correlation. We also know from data in the NHS that staff satisfaction is not solely about how you design that product. In fact, it's not even mostly about how you design that product. About 30% of staff satisfaction is associated with a product at all. The other 70% are to do with its reliability, how much education you've had, how customized it is to your workflow, and the quality of your leadership. We know, for instance, that if you have just 1 hour's worth of training in your digital product, in your electronic patient record, it results in about a 17-point difference in staff satisfaction on average. That's a fairly cheap intervention for what is a major benefit. We also know that there's a link between staff satisfaction with an EPR and staff burnout and staff retention. It's not the most important thing. Staffing is the most important thing that's adding to stress to the modern day clinician. But digital is not far after. In fact, in the top 5 things that are causing stress, digital is a strong component of 3 of them. So when we talk to those, that workforce, they broadly said 2 things. Stuff on the right-hand side is, right, your technology is neither usable nor available, and I'm overinflating that slightly for effect, but that is broadly speaking what we heard. On the right-hand side, they said, oh, and by the way, we don't know how to use it. And there's lots of things behind that. People don't have time to train. There is an issue with basic digital literacy in the NHS. The average NHS worker is less digitally literate than the average UK worker. So if any of our strategies involve trying to take our staff and train up patients, it's kind of the other way around, actually, guys, in many cases. And it's not a small issue. 20 million people in the UK do not have all of the 20 essential digital skills for work. In the NHS, that translates through to about 3 out of every 20 people not having even 5 of those essential digital skills for work, and 1 out of every 20 having none at all. So when you're starting to ask people to use a complicated digital product, an electronic patient record is a very complicated digital product, and they've never used a mouse before, or they're fine doing the Tesco Big Shop, but they don't know how to type, and there's one workstation on wheels and there's a big queue of people and they're very flustered, and if they've hit the wrong button, then they're going to lose all their data. It's causing issues, and we are starting to see people citing the introduction of technology as the reason for leaving the NHS. It's an issue. So I promised 3 tips. Number 1, let's invest in some product-specific training. Let's not treat a product as just the cost of a license or the cost of that product. Probably about half of your effort needs to be on all the change management stuff that Ali was talking about. And importantly, education. This is the data from the English NHS from last year's usability survey that says a 17-point difference in staff satisfaction can come from just 1 hour's worth of training. And incidentally, 44% of the NHS workforce received no training in their EPR last year. That would be my number 1 quick win. Number 2, this is just some research that came from a partner of ours, a charity called Future.now. They look at the evidence about what works and what doesn't work around basic and essential digital skills. All the stuff that really works is on the left. You might not be able to see it, but it's the Learning That Clicks report. It is open access. Please do have a look at it. All the stuff on the right is the stuff that doesn't work. Bite-sized learning works. Online learning does work, but actually the best thing that you can possibly do is introduce a digital champions model. People want to learn from people like them. Doctors want to learn from doctors, nurses want to learn from nurses. They want to know the answer to their problem immediately. They want to know it right now. Do not send them on hours-long or days-long training. Support a relatively small number of people, ideally in every single locality, to be able to help them through problems as and when they have them. So that'd be my 3 very specific things. There are other things we can do. Make sure that if you work in digital, make sure you actually define what your benefits are and then measure them, please. Keep focused on the quintuple aim, like Alec mentioned. Use best practice, don't reinvent the wheel. Please do share what works and what doesn't. We're not always great at doing that. And in the Digital Academy, we do have a couple of platforms. We've got a Future NHS page, we've got a special interest group. Do join, do share, do tell us what's happening. I promise you'll get a platform. And finally, do use educational resources when provided. Fundamentally, though, our workforce do need to be treated with kindness. And we do need to make sure that we support them in their very, very specific needs to learn in their very specific way. And if we can do that through a bit of friendship, so much the better. Thanks very much.
Thank you, James. Okay. I always think that with EPRs being so different, if airplane cockpits were as different from one plane to the next as EPRs are between one hospital and the next, you wouldn't be surprised if there's a crash every day. And I think that's something, like ubiquity is a word that you never hear mentioned in terms of the user interface. And yet, we have that in other things, like I can drive a car, and I could get in someone else's car and probably make a decent fist of driving it, even if I've never been in it before. But we don't have that for EPRs. And that's a real drain. It's like a drag effect on clinical effectiveness. Okay, so let's move on to the questions, Q&A. Perhaps if, Sarah, if you want to come up as well. Well, we can give Sarah one of the roving mics, and I will run around for any questions. So.
Hello. Yeah, thank you for both the presentations. I was a bit late for Sarah's ones, but I saw the general idea. I have a generic question that I was thinking even before coming to the conference when I saw the people who were going to talk. So you mentioned your perspectives in terms of the digital, but I wondered if you could tell us what is your view on the wider picture in terms of digital, regardless of health or not, and how it and which role it plays with the implementation of digital going ahead. What I mean is, the social media problem, the fake news and misinformation. How do you feel that plays Is it a good thing about it's making it the environment easier, or is it making it harder, both for patients' perspectives, but as well as healthcare professionals in terms of acceptability, trust, and relying on these digital tools? Thank you.
Well, I think it's quite simple from patients' point of view. It drives fear, and misinformation is ghastly because it sets hairs running that don't need to start running, and it makes people very fearful and less open then to hear the proper or the factual answers, because they feel that they've read it on Instagram or Reddit or wherever, it must be true. So I think that's really quite a problem.
Yeah. I mean, if I should add, I think that the NHS workforce's perspective is very, very similar. So, and quite frankly, even as an ex-chief information officer, the scale of change is terrifying. And I can't keep up with it all. I never could, and I definitely can't now. The way in which we deal with it, however, I mean, so for instance, things like artificial intelligence, right? People have got free access to open access generative AI, which gives you incredibly credible results. You can ask anything and you can get a really believable answer which speaks to you, regardless of whether it's right or not. And that is super dangerous. My view is that regardless of whether you're a member of the workforce or a member of the public, we need to support people to sort truth from falsehood, and we need to help people to learn, because now we can't teach everything to people now. We need to help people learn on their own, at their own pace, dealing with their own problems and their own objectives and their own passions and their own ambitions at the time at which they need to do it in a way that gets them to the right answer.
Which is very challenging, isn't it? So what you're talking about is critical skills, which I was in an event on Monday in Sheffield, and someone said that the average reading age for the UK population is 9-year-olds. And then I was like, if people don't have skills to read, how could we develop their skills to be critical on those things that are coming out? So it's a challenge that we all need to be thinking about, isn't it? Thank you.
They'll go to the nurse or they'll go to their GP, and the problem is GPs will be overloaded because they'll ask more and more questions, and that puts it back on the NHS, which is a real battle.
Hi. Sorry, this is a very specific question for James. I acknowledge this is maybe a me problem a little bit, but I just wonder what your thoughts are. So, I mean, first off, I'm in this room, so I'm probably starting off with a score of 4 for in terms of net promoting for a thing. But I find after I've had training for an EHR, I'm actually more frustrated. My satisfaction with the product is generally lower than what it was. If you gave me an hour of training, usually it's not tailored to me, or if it is, it's telling me something I already know, and it just annoys me more. Like, well, yes, I accept I'm in this room and I'm me as well, but like, what do you think? How generalizable do you think that view about the training thing is, when there are clearly more people than just me in this room that also kind of have that? What are your thoughts on my oddity there?
Yeah, I don't think it's an oddity at all, and I should say asterisk caveat. Limited amount of time talk. Let's get through to some main points. There will be lots of people, I suspect, in your camp who have a small amount of training, and oh my God, half of that was useless, irrelevant to me. Why does it do it that way? Why do I need to click 3 different things when, I should just be able, and why is it giving me the wrong data? So lots of different frustrations and reasons to be frustrated. I get it. Hopefully, it's not going to make you less safe, the training. All I can tell you, though, is that's the data, that is the true data, right? So in 2020, there was a usability survey around staff satisfaction. There absolutely is a correlation between how much training you do and how satisfied you are with the system, and you saw that data. There's a big jump between nothing and a little bit, and then there's not that much of a difference between a little bit and a huge amount of training, right? So, and the reason I say it is because we work in an environment where any training at all is definitely an afterthought, right? It tends to be something that's done once, and if you're not on shift that day, or if you're poorly, you don't get a chance. Or if you can't be released, right, you don't get a chance. And that is driving people leaving and patient harm. So in a world where, yeah, okay, a little bit of training is frustrating, but it is better than nothing, is, I guess, what I'm saying. And by the way, I'm not advocating for not having better digital technology. I'm just saying that doing a little bit of training is both quicker and cheaper than trying to address the issue of getting amazing, what was the word you used, Marcus?
Ubiquity.
Ubiquitous, thank you, electronic patient records and experience.
This is a question for James Freed. Do you know how you measure digital confidence?
You're always great at asking me the difficult questions, aren't you? Thank you. I believe it's the way in which we're going to try and tackle it is simply asking people how confident they are in using the digital technologies and data they're asked to use on a day-to-day basis. There's an evidence base that demonstrates there is quite a strong correlation between how people think that how confident people feel they are and their actual capability. There's a little bit of difference. But there's quite a good evidence base to demonstrate they're good enough. What I would say is there is also an evidence base to say that people don't really like answering 32 capability-based questions when they tend to know where their own weaknesses are, and they tend to have a value base on whether to try and address those weaknesses or not. And also, we have seen literally no site in the UK take a 32 question-based capability questionnaire on digital literacy and turn it into any sensible action. So our advice at the moment is probably a single question on something as simple and subjective as how confident do you feel in using the digital technologies you're asked to use at work?
Thanks. Question for James, just more on the training point. We talk about kind of prevention being better than cure. Obviously, a lot of these problems stem from the tech not being optimal, so therefore kind of training is needed. How much responsibility can we place on the providers like the EHR companies, and also Marcus mentioned standardization of software, which you see in other sectors? How can we kind of encourage that shift? And then also on the training point, how much responsibility can we put on the providers to provide useful training resources, courses, guides, etc., so there's not as much overhead on the NHS to help staff with this?
Yeah, the answer is some, but less than half. Definitely less than half. Right, number one, if you accept that staff satisfaction is a good proxy measure for how good your EPR is, I guess, then we know that the choice of the product and everything to do with its design accounts for less than half of staff satisfaction, about 30%. Secondly, you can't outsource risk. You can't. So if you have a conversation with a supplier, you buy in their product, you can ask them to deliver all the training in the world, but it won't be perfect for everyone. Exactly as Sarah was saying, there is a unique element to this. And supporting the nurse who has never used a mouse before is very different from the doctor who codes in his spare time. They've got different learning needs, probably different learning styles. And that learning need is forever. You will always need to have some element of education around digital skills within your organization as you've got a churn in people and the technologies you choose to use changes. But fundamentally and most importantly, your supplier does not own the fact that if your workforce doesn't use that product well, people die. You own that risk, and you can't outsource it.
Can I make a point that nurses and medical staff were originally used to care for people? You're now asking them to manage digital technology and care for people. And they might be very good carers, but very poor digitally. And you're asking a really big ask to expect that the two may actually go hand in hand. And I wouldn't want you to lose sight of that, because if they become digitally great, but they're absolute rubbish carers, then we've gone backwards. So I think the emphasis has to be on the care side, and the digital thing has to be enhanced. And I'm sure the younger generations will just walk it. It'll be absolutely fine. But it's managing the current generations and maybe a couple of generation behind and bringing them through, because we cannot lose the care. because that's what we want. We don't want someone with an iPad looking at us and reading everything off about us on the screen without actually looking at the patient. I think that's critical. And I'd just point out that Southampton has an app for its medical letters, and we have the NHS app. When they upload onto Southampton, you can't access the NHS app. They upload the Southampton one at 11:30 at night, so if you have the mistake that you can't sleep and you open it up, you can be awake all night. Can I make a plea that you put all letters at 9 o'clock in the morning so people at least have a decent night's sleep and they're not lying there worrying because they can't phone anyone to ask what the poorly constructed letter with no kindness in it whatsoever is stating. So all of these things need to be thought through. How you actually interact with patients with your digital technology. Sorry. Did everyone hear me anyway without it? Yeah. Sorry.
Okay, I was going to come in. Can you hear me? Yeah, I was going to come in on that point. So 3 points. One is technology doesn't heal. People do. And the greatest innovation, despite, and I sort of made a flippant comment about AI, but the greatest innovation in healthcare, in life right now, is not AI, it's human intelligence. Okay, so it's about humans in the loop. This is about, I could have helped write Sarah's speech for her, but she did it beautifully. So, and that's why I sandwiched people with digital in the middle. This is all about creating a culture of connection, collaboration, better communication skills, but it's ultimately about compassion, and it's restoring the art of medicine. But on your specific point, my reflections, having been in this post now for 12 months, but having been on a digital journey for the last 17 plus years, is we've invested billions in technology that's not usable and it's not functional. And we've not invested in the change management to train staff to use it, recognizing it's not ubiquitous, it's all hugely varied, and we've just created more unwarranted variation with digital than we did with paper and pen, which was at least consistent. You couldn't read doctors' handwriting. At least that was consistent and standardized. So the data use and access bill is going to fundamentally change the relationship with suppliers. The language I'm using is we need them as a collaborative partner, because if we're going to truly deliver anything close to the 10-year plan and sustain the NHS in its current guise, then we need a collaborative effort between the NHS, the care sector, BCSE, academia, and commercial and industry. But it's got to be on our terms. We cannot continue to have solutions being implemented badly that don't deliver against the functional specifications that were in an OBS in the first place, and then let's do nothing about that. So really strongly, we need to hold suppliers to account to deliver on what's required, and I think that's really important. And the final point is, that's the very reason I put out the notice back in June about ambient voice. And we'll be very imminently, probably in the next week, there'll be a self-registry coming out which will hold suppliers to account on their business capabilities and the functional specification and requirements in a standardized way against demonstrating compliance. And that's there are global players now who have accredited as a medical device. They had no intention of doing so. So we are changing the conversation. It's got to be collaborative, but we've absolutely got to gently hold their feet to the fire.